Ladies and gentlemen, estimated colleagues, dear friends, I have the honor to introduce the Kessel lecture, and nobody has the need to the introduction to Lippmann Kessel, one of the giants who wrote the history of shoulder surgery. And this lecture is one of the most important of the entire meeting of the ICSES, and this time this will be held by Professor Eiji Itoi from Japan. He is professor and chair of the Department of Orthopedic Surgery of the Tohoku University School of Medicine. This is his research and professional experience. He was a junior resident in a National Meat Hospital, then senior in the same hospital, assistant and instructor at the Tohoku University Hospital, and then he became assistant professor and later associate professor in the Akita University Hospital and School of Medicine, and finally professor and chairman in the same university. He did research fellowship in the Mayo Clinic, senior research fellow in the Mayo Clinic, and visiting scientist in the Mayo Clinic. The list of the awards and honors that Professor Eiji Itoi got in his career is very long, starting in 1991 with the Scientific Incentive Award, Department of Orthopedic Surgery in Tohoku University. But probably some of the most important are the NEED awards. He was the first traveling fellow of the Japan Shoulder and Elbow Society and the European Shoulder and Elbow. He started a new road. He got Scientific Award, American Orthopedic Association International Traveling Fellowship in 1997, and again 2003 a NEAR Award, and then the Rick Kaspari Award in the ICSES. He had many responsibilities, giving a great contribution not only from a scientific standpoint, but also from an organizing standpoint to the entire shoulder community. He was a reviewer of the JBJS from 2004, editorial board in the American Journal of Sport Medicine, and then treasurer, International Board of Shoulder and Elbow Surgery. So the ICSES was taking care of these congresses. He has a lot of publications, including books and book chapter 56, review articles 45, and original articles 320. That means a lot. Numbers are speaking more than words. He had presentation in over 700 congresses and meetings, forum lectures over 100, and reports and others 23. So very active from any point of view. Like every intelligent person, he never forgets who was putting him on track. So his mentors. His mentors are the clinical mentor, Dr. Shiro Tabata, here with the younger Eiji Itoi. The research mentor, Professor Kainan An, since 1990 is cooperating with him and learning from him. And these are the most important awards he got. This is the NEAR Award in 1992. This is during the first Japan and European Shoulder and Elbow Traveling Fellow with Christian Gerber in 1994, 22 years ago. Here is with Herbert Resch, who is in the room now, during the same traveling fellowship. And here is with Jill Walsh. Of course, both were much younger. Here, Gary Garsman is delivering to him the NEAR Award in the American Shoulder and Elbow Surgeon Society in 2003, his second NEAR Award in his career. He was a guest speaker at the American Shoulder and Elbow. Here is with some friends, including Baz Burkhead in 2007. He was a guest speaker at the Second Congress 2011 in Lyon, here with Pascal Boileau and Gilles Walsh. But he's not only a researcher, he's an active man. He likes sports, like surfing, swimming, and here is snowboarding with some risk for his shoulder with Laurent Lafosse during the Val d'Isère course. But also he likes arts. He's an organist, and he's a very good one. And as I always mention, science, surgery, and art have some link. And Professor Eiji Itoi is a good example of that. But also he is a friend. He's able to interact with everyone, with many different communities, from East, Far East, and West. Here in the top left image is in Italy for the Italian Shoulder and Elbow. This picture is in Japan, and you see the Italian flag and the Japanese flag. We are in Korea here. This is why I put this picture during the Korean shoulder and elbow meeting. And here with Evan, representing the link between different continents, different culture, but with the same love, shoulder surgery and research. Again, ladies and gentlemen, it is a great honor for me to invite Professor Eiji Toi to give his Kessel lecture in the ICES about shoulder instability.
Thank you, Alex, for your very kind introduction. Good morning. I'm Eiji Toi from Sendai, Japan. It's my great honor to be here as a Kessel lecturer. So I'd like to say thank you to the President Yangari and all the organizing committee members of the KSES for giving me this opportunity. This morning, I would like to talk about the shoulder instability, mainly focusing on two issues and some future perspectives and some message to the young doctors. As we all know, the biggest problem of shoulder dislocation is the high rate of recurrence. There are many factors related to this issue, but one of them is the healing of the Bankert lesion. Carter compared the various lengths of immobilization starting from 1 week up to 6 weeks, but he could not find any significant difference. And then he compared various degrees of rigidity starting from casting, the most rigid type of immobilization, all the way down to no immobilization. But here again, he could not find any significant difference. But that is very difficult to understand, because when you think about the healing of this tissue in our body, that should follow these two rules. For example, when you treat the Achilles tendon rupture, you immobilize the ankle in plantar flexion and keep it in that position for a while, then you can expect the healing. However, if the immobilization is too short or too unstable, then healing may not occur. The only situation that these two rules cannot be applicable would be something like this. If you immobilize the ankle in dorsiflexion, then the length or rigidity of immobilization would not affect the outcome because there's no healing. So something like this might have happened inside the joint when we do the conventional immobilization of internal rotation. That's the very beginning of this study. We look at the MRI, which showed that the anterior capsule is away from the bone and the labrum is medially displaced with the arm in internal rotation. However, with the arm in external rotation, the capsule is back to the bone and also the labrum is well reduced. So if we keep the arm in this position, then we may expect the healing of the lesion, and accordingly, we can expect the decrease in recurrence rate. So we performed a multi-center study, and this study shows that according to the intention to treat analysis, the recurrence rate was 42% versus 26%, and according to per protocol analysis, they are 39 versus 20. So we could have a relative risk reduction of 38% to 49%. After our study, there are several prospective randomized studies reported in the literature, and this is the recent meta-analysis, which shows that the relative risk reduction was 31%. However, this was not statistically significant. I wonder, you may think that, oh, this treatment doesn't work, but it's too early to say so, because during the Academy this year, there was a paper from Canada comparing two types of immobilization, and they concluded that external rotation immobilization is effective in reducing the recurrence rate. So adding this new study, this is the most recent meta-analysis, and relative risk reduction was 36%, which is statistically significant. So I think we need more studies to find out the real effect of this treatment. Treatment strategies, of course, there is no question that surgical stabilization provides the best shoulder stability for the patient. There's no question about that. However, that does not necessarily mean that you have to do the surgery for the initial dislocators, because this number needed to treat analysis show that in the high-risk group, the number needed to treat is 2.6, whereas in the low-risk group, the NNT, it's calculated to be 7. That means if you do the stabilization surgery in 7 patients, then you can save 1 patient from recurrence. Or in the high-risk group, if you do the surgery in 2.6 patients, then you can save 1 patient from recurrence. So if you do the stabilization surgery for each and every one of the initial dislocators, then you will end up doing unnecessary surgery in 60 to 85% of the patients. So the authors concluded that there was no sufficient evidence to support the routine use of prophylactic repair for all primary dislocations. The word prophylactic repair is the key word because when we do the surgery, it's a treatment. For the initial dislocators, they do not have chronic instability yet by definition. So if you do surgery, it's a prevention of chronic instability yet to come. You never know whether it really comes or not. So it's a prophylactic surgery. Well, I would accept prophylactic injection like a flu vaccination, that's fine. But would you prefer to have the prophylactic surgery? That's the question. However, the recurrent dislocators are quite different because they already have twice or more dislocations. They have chronic instability already. So if you do the surgery, that's the treatment of chronic instability. So that this treatment would be 100% warranted. So this is something we need to keep in mind when we treat the patient. Of course, the in-season athletes would like to go back to sport. So in that case, this kind of a protective brace would be effective. The recurrence rate was 38%. So our treatment strategy is for the high-risk patients who want to avoid recurrence even with surgery. Then I think surgery is indicated. But according to our survey, that's only 11 to 27% of the contact athletes. In-season athletes, probably the protective brace would be indicated. Off-season athletes and non-athletes, I think the conservative treatment would be indicated. If the patient accepts to immobilize the shoulder in external rotation to reduce the relative risk by 36%, then I think the immobilization in external rotation is indicated. But if the patient prefers not to immobilize the shoulder, that's fine, just let them go. Because there's no difference with no immobilization versus immobilization in internal rotation. So if you don't like it, just let them go. So anyway, there's a definite group of patients who really want to have the conservative treatment. That's why I think it's worthy to find out the best conservative treatment that we can offer to the patients. Right now, immobilization in external rotation has not been finalized yet because it's still developing. We need to find out the best position. This study from British, they observed the shoulder after initial dislocation, and they found that 92% of the Bankert lesion was reduced with the arm in a deduction external rotation. However, the best reduction was achieved with the arm in 30 degrees of abduction, 60 degrees of external rotation. When you look at the Bankert lesion, it's displaced anteriorly but also it is displaced inferiorly. So for the best reduction, we need to apply the posterior force created by external rotation, as well as the superior force created by abduction of the shoulder. So we performed this study. After reduction of initial dislocation, we took the MRI in 4 different arm positions: adduction internal rotation, adduction external rotation, abduction 30 degrees of external rotation, and abduction 60 degrees of external rotation. We took the MRI and we used these radial sequences to measure the displacement of these soft tissues. These images are taken with the arm in adduction, and these images were taken with the arm in abduction. The inferior labrum seems to be better reduced with the arm in adduction. So we measure the separation, displacement, opening angle of the anterior capsule, and this is the separation of the anterior labrum, which was significantly reduced with the arm in external rotation, regardless of abduction or adduction. However, the separation of the inferior labrum was significantly reduced only when we add the abduction to the shoulder. The same thing for the displacement or opening angle of the capsule. So in order to get the best reduction of the tissue, the abduction and 60 degrees of external rotation is the best position. The question is this position acceptable for the patient? So we performed the next study using a brace. We asked the volunteers to wear this brace in 4 different arm positions, 24 hours each in random order, and we asked them how difficult it was to do activities of daily living. The activities of daily living was significantly more difficult with the arm in 60 degrees of external rotation compared to with the arm in adduction. Similarly, the discomfort the volunteers felt was significantly greater with the arm in 60 degrees of external rotation compared to these positions. And the 30 degrees of external rotation is located somewhere in between. So in terms of reduction, the abduction, 60 degrees of external rotation is the best. But in terms of comfortability, it is the worst. So probably when we think about the clinical application, I think it would be the best to choose the second best position for the comfortability of the patient. And right now, the Japan Shoulder Society is planning to do the multi-center prospective study comparing internal rotation versus abduction and 30 degrees of external rotation to see its effect on recurrent dislocation and on the WOSI score. Let me talk about the bone loss next. As you know, the shoulder with anterior instability often have the bony lesions of the glenoid and the humeral head. In our series, 86% of them had bony lesions of the glenoid, and 94% of them had Hill-Sachs lesions. And in total, 81% of them had both of these lesions at the same time. We call it bipolar lesion. So 4 patients out of 5 have this bipolar lesion, so we have to be very careful. What is the critical size of the glenoid bone loss? Well, if you look at the old textbook, it said if the glenoid defect is greater than 1/3 of the glenoid surface, you must fix it with bone graft. Well, if you look at this, how large is this defect? Is it 1/3 or 1/4? You never know. So as long as we use the eyeballing method of quantifying the defect, it's not scientific. We need to be more precise in quantifying the defect size so that we can clearly say this is the critical size of the defect. So first what we did, was we look at many dry bone glenoid, and we created this average shape of the glenoid. Using this, we made a bone defect here, but measuring the area is very cumbersome. It's very difficult. You need some kind of software, so this is not good. What we can do easily is measuring the length. All you need is just a ruler. So we decided to use this L, normalized either by the width of the glenoid or by the length of the glenoid. This way, we can successfully and easily quantify the glenoid bone loss. Using this method, we created the bony defect stepwise and repaired the Bankert to see how these bony defects affect the stability. This is the end range stability. The red bar shows the stability after the Bankert repair, and even with a large bony defect, the stability did not decrease significantly. However, the mid-range stability decreased significantly after creating this number 2 sized bony defect. After this study, there are several biomechanical and clinical studies reported, and these days we have a consensus that when the glenoid defect is 25% or greater, then the stability of the shoulder cannot be restored even after the Bankert repair. Whereas if the defect is 17% or less, the shoulder stability would not be affected. So the 25% is the critical size, but the zone between 17 and 25 is a gray zone. This study from Shahad's group, they look at the military patients after arthroscopic Bankert repair, and they divided the bony defect into 4 quartiles. In terms of failure rate, the quartile 4 was significantly worse than others, and quartile 4 means the defect was greater than 20%. However, in terms of WOSI score, the quartiles 4 and 3 were unsatisfactory, and the quartile 3 means 13.5%. So more than 20%, the recurrence rate is the problem. So this is the critical size, and between 13 and 20, recurrence is not an issue, but the patient have discomfort, pain, or positive apprehension. So they defined the zone between 13 and 20 as the subcritical bone loss. We used to say that the critical size of the glenoid bony defect is 25%. However, the border between stable and unstable is not that clear. There is a transitional zone. According to the biomechanical study, this zone ranges from 17 to 25%, and according to the clinical study, it's shifted a little bit to the right because they are dealing with the military patients with high risks. So we need to know more about this subcritical bone loss. Regarding the critical size of the Hill-Sachs lesion, it's a little bit more complicated because the same Hill-Sachs lesion can be stable or unstable depending upon the size of the glenoid. This Hill-Sachs lesion is covered by the glenoid, so it is stable. But if there is a bony defect anteriorly, then this glenoid drops into the Hill-Sachs lesion. It's an engagement, it's a dislocation. So for the assessment of the Hill-Sachs lesion, we need to look at the bipolar lesion. But if you look at the literature, they all look at the size of the Hill-Sachs lesion, depth or volume, and none of them paid attention to the glenoid. For the risk assessment of the Hill-Sachs lesion, we have to incorporate glenoid bony defect as well. And for that purpose, there are 2 methods. One is dynamic examination. During arthroscopic surgery, we may bring the arm to apprehension position, and this Hill-Sachs lesion easily engages with the anterior rim of the glenoid. So you may think, oh, this is an engaging Hill-Sachs lesion. However, after the Bankert repair, the head is well centered, and this Hill-Sachs lesion is far posterior from the anterior rim of the glenoid. So after the repair, it doesn't engage anymore. So this is not a true engaging Hill-Sachs lesion. This is a so-called pseudo-engaging Hill-Sachs lesion. If you look at the literature, almost all the investigators reporting the prevalence of this pseudo-engaging Hill-Sachs lesion. There's only one study in which they performed dynamic examination after the Bankert repair. According to Park and colleagues, the prevalence was 7%. This is the right way to do. However, you repair the Bankert, and right after that, you bring the arm to this position. You may break your repair. There's always a risk of damaging the repair. In order to avoid this risk, we recommend the other method, that is the glenoid tract concept. The glenoid tract is the area of the humeral head covered by the glenoid when you move the arm along the posterior end range of motion. If the Hill-Sachs lesion stays within this tract, then the shoulder is stable. So first, we use cadaveric shoulders, move the arm to maximum external rotation and maximum horizontal extension, and elevated the arm from 0, 30, up to 60 degrees. And as you see here, the glenoid moved along the posterior margin of the articular surface of the humeral head, creating this zone. So we call this zone the glenoid tract. If the Hill-Sachs lesion stays within this tract, there's no chance that this Hill-Sachs lesion engages with the anterior rim of the glenoid, because the anterior rim of the glenoid is here. There's not a single chance that it engages with the Hill-Sachs. However, if the Hill-Sachs lesion is located here, then there is a risk of engagement in this area. The glenoid tract is created by the glenoid itself, so when it is intact, it's the widest, and when there is a bony defect, then it becomes narrow. So we need to know where this medial margin of the glenoid tract is. First, we measure the width of the glenoid, which is 100%. Then this medial margin is located at 84% from the footprint of the rotator cuff. If there is a bony defect like this, then we need to subtract this bony defect width from 84% value to obtain the true width of the glenoid tract. Next, we measure the glenoid tract in live shoulders, moving the arm along the posterior end range of motion. We took the MRI simulating this motion, and then we created these 3D skeletal images. And then, finally, we fixed the humerus and let the glenoid move on the humeral head. So this is the glenoid tract observed in live shoulder, which is quite similar to the one we observed in cadaveric shoulders. Using this method, we found that the glenoid tract was 83% with the arm at 90 degrees of abduction, and it becomes a little smaller superiorly and a little wider inferiorly. So how can we incorporate this to our clinical practice? We need the en-face view of the glenoid of bilateral shoulder. Don't worry about the radiation exposure, because when you ask the radiologist to take the CT scan of the right shoulder, then they already have the data of the left shoulder as well. Because when you take the CT, both shoulders are inside the CT gantry. They always take bilateral shoulder at the same time. So all you need to do is ask the radiologist to create the glenoid image of bilateral shoulders. First, look at this intact shoulder, and this is 83% of the intact glenoid. Then bring this to the involved side. There is a bony defect here, so you measure this defect size, and you subtract this from the 83% value. So this is the true width of the glenoid tract. Bring this to the humeral head, and this is the glenoid tract in this particular case. When the Hill-Sachs lesion is out of this glenoid tract, we used to call it engaging Hill-Sachs lesion. However, as I said, sometimes the word engaging is used to describe pseudo-engaging, so it's very confusing. So instead of saying engaging Hill-Sachs lesion, we recommend to use the word off-track lesion, because this lesion is off the glenoid tract. Similarly, if the Hill-Sachs is entirely covered by the glenoid tract, instead of saying non-engaging Hill-Sachs lesion, we recommend to call it on-track lesion. How often do we see the off-track lesion? In our series of 100 cases, we saw this off-track lesion in 7% of the cases. This was exactly the same as Park's report using dynamic examination. So what should we do for the off-track lesion? There are two methods. One is to fill this defect by bone graft or remplissage. The other method is to fix this glenoid bony defect by iliac bone graft or coracoid transfer. By doing this, you can widen the glenoid tract and you can convert off-track lesion to on-track lesion without touching the Hill-Sachs lesion. But one thing I would like to say is about the remplissage. According to our biomechanical study, if you do the remplissage, then the horizontal extension and external rotation was significantly reduced. So we cannot recommend this procedure for the throwing athletes. Our treatment strategies are this. On-track, small glenoid defect, just fix the soft tissue. On-track, large glenoid defect, we must fix the glenoid defect by Latarjet, for example. Off-track, small glenoid, it's a good indication for remplissage, but if the patient is a throwing athlete or collision athletes with high risks, then you might want to perform Latarjet. That's fine, because by doing Latarjet, we can convert off-track lesion to on-track lesion. Off-track lesion, large glenoid defect, we must fix this glenoid defect by Latarjet. And in our series, 93% of them were repaired by soft tissue alone, and the off-track lesion was observed in 7% of the cases. It's not a large percentage, but if you miss them, then you cannot provide the best treatment to the patient. There are a couple of validation studies reported using this off-track concept. One study is this. They created bipolar lesions using cadaveric shoulders. With the on-track lesion, all engagements were prevented after Bankert repair, but with the off-track lesion, none of them were prevented after Bankert repair, but all of them prevented after remplissage. This is a clinical validation study. They perform arthroscopic Bankert repair with recurrence rate of 18%. Using the off-track sign as a predictor of failure, then the positive predict value was 75%. Using the glenoid defect more than 20% as a predictor, then it's only 43%. So they concluded that off-track method was accurate and encouraged as a routine pre-op evaluation. Well, we need to know more about this glenoid tract. I said the glenoid tract is 83% of the glenoid width, but that's the average value, and it depends on the range of motion of your shoulder. For example, this is my shoulder with the arm in horizontal extension. The glenoid is located closest to the greater tuberosity, but with the arm in horizontal flexion, then the glenoid moves away from the greater tuberosity, making the glenoid tract wider. And with the arm in horizontal extension, the glenoid tract becomes narrow. So if I have a limited range of motion in horizontal extension, that means my glenoid is a little bit away from the greater tuberosity, and my glenoid tract would be a little wider than 83%. So right now we are working on this issue, and at this point we cannot say any conclusions, but in the near future, hopefully we can provide the best way to predict the individualized glenoid tract using the range of motion. Future perspectives, well, people used to say the hip and knee are major joints, like a king and queen, and all the other joints are subordinates. And in order to stand up against the major joints, sometimes these subordinates combine together, like shoulder and elbow, or foot and ankle. But shoulder is even worse because it used to be called the forgotten joint. It's gone. But thanks to all the shoulder surgeons in the world, shoulder has become one of the major joints these days. It's so important, thank you. It's so important that it contributes to the noble triangle. For those of you who are not familiar with the noble triangle, let me explain it to you. Our body has a very important organs. One is brain, heart, shoulder. These three important organs create the triangle, which is called noble triangle. No joints other than shoulder can create this triangle. For example, hip joint, just a straight line. Knee, straight. Ankle, straight. Only shoulder can create this beautiful triangle. So we know that shoulder is as important as brain and heart. It is so important that these days there's a big movement, global movement, that shoulder is getting independent from other joints. For example, ICSES used to have the upper extremity committee, which deals with all the joints in the upper extremity. However, last year, this committee split into two committees. One is the shoulder committee, focusing on the shoulder joint alone, and the other committee is dealing with all the other joints in the upper extremity. Sometimes we call this committee lower upper extremity committee. Does that make sense? Well, anyway, shoulder is these days a very important joint, so probably we should be independent. If you ask this man, he would probably say, okay, I will build a great, great wall on the border of shoulder and elbow, and I will have elbow pay for that wall. Well, it's a very radical comment. But as you know, there are many societies related to shoulder in the world, and I don't think there would be any problem to be independent, except one society. You know what? It's American shoulder elbow surgeons, because if you take the elbow away from this, it's this. So I really hesitate to call myself, I'm the corresponding member of ICSES. But anyway, some comments to the young doctors. As Alex introduced me, I'm very blessed to have two great mentors in my life. Dr. Tabata taught me a lot about shoulder surgery, how to communicate with the patients, and also Dr. An taught me a lot about shoulder biomechanics. I owe them greatly, and I owe them what I am right now. Also, I'm very blessed to have great co-workers with me who worked very hard to achieve the goals set before them over the last 25, 30 years. So I really appreciate them. So it's very important to have a good team, but also it's very important what comes out of you. That's originality. If you just copy, 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 nothing new comes out of you. The originality is the most important and precious asset of us. And it comes from questioning why. For example, I talk about the immobilization and the glenoid tract. These concepts came out from asking why. Why doesn't the immobilization work? Why doesn't the same-sized Hill-Sachs lesion creates instability in one shoulder and not in the other? Just keep questioning these whys, and then eventually you'll be able to find the answer. Albert Einstein said, learn from yesterday, live for today, hope for tomorrow. The important thing is not to stop questioning. So I'd like to say my first message, don't stop questioning. But in order to keep questioning, you need to understand it yourself. So what is understanding? Well, there's an interesting definition by Einstein. He said, if you can't explain it to a 6-year-old, you don't understand it yourself. So let me explain this glenoid tract concept to a 6-year-old. You are standing on the solid ground, no problem at all. But once you step onto a pit, then you will fall into the pit. Whether you fall or not depends on where you are. The depth of the pit doesn't matter. The volume of the pit doesn't matter. It solely depends on where you are. The same thing for the glenoid tract. You are standing at the anterior rim of the glenoid. So as long as you are standing on the solid humeral head articular surface, nothing happens. But once you step onto the Hill-Sachs lesion, then you fall into the lesion. The depth or volume doesn't matter. What matters is the location of the anterior rim of the glenoid. That's the very basic concept of the glenoid tract. If you love what you are doing, you will be successful. I totally agree with Dr. Schweitzer. So my second message to the young doctors are, love the shoulder as yourself. Well, this is far easier than love your neighbor as yourself. Or love your enemy, sorry. Love your enemy as yourself. Well, if I ask you what comes first in your life, you may say, my family, job, hobby, whatever. One of my colleagues said, number 1, shoulder. Number 2, bugs. He loves beetles and stag beetles. Number 3, family. So I don't know whether this is the right order, but I tell you, he is a true shoulder surgeon. I respect Dr. Schweitzer as a physician. He devoted his life in saving the lives of children in Africa. Also, he was a peace activist. Together with Albert Einstein, he worked hard against the nuclear test or nuclear weapons, and eventually he received the Nobel Peace Prize. I also respect him as an organist. He was a famous organist at that time, but there was no organ in Africa. So when he moved to Africa, his friends presented him with this pedal piano so that he can practice anytime. Whenever he came back to Europe, he had organ concerts for fundraising. In 1954, he received the Nobel Peace Prize, and after the ceremony, he played the organ at the church, Trinity Church in Oslo. Well, I have not received the Nobel Peace Prize yet, but I have the opportunity to play the organ at St. Peter's Cathedral in Vatican. You may ask why. Yes, that's very important. Keep asking why. This is Francesco Franceschi, one of my friends, who has a Vatican citizenship. Thanks to his help, I got a special permission to play the organ at Basilica di San Pietro. This is really a once-in-a-lifetime experience for me, so I would like to share the sound of this great organ with you to finish my talk with. Thank you very much.
Wait.
Can you stay there?
Stay there.
In the honor, we'd like to present our letter of appreciation to Professor Ichi Doi. The title, Shoulder Instability, date May 19th, 2016. On behalf of 13th International Congress of Shoulder and Elbow Surgery Organizing Committee, we would like to express our deepest gratitude for your outstanding contribution to the Congress. Thank you. Thank you, Alex, and thank you, Ichi, for this lecture. Thank you, all the participants, for sitting here and listening.